I was a problem unmuting. So thank you, Dr. Milanese and the committee for inviting me today. It's such an honor to come and talk to you at this very important meeting. What we're going to show today is a kind of a new look at all problems and offering simple solutions where solutions are otherwise very complex. So I'm going to show a case here, and first, just introducing the problem itself. Usually, in the lumbar spine, when we have disc herniations, most times we need to do nothing unless there is a coda equina, and only a few end up getting any operation as this spontaneously is resolved. Over time, there's been a great number of approaches that's been developed depending on where the problem is and what the instrumentation and technology is available. So I'll start with this case of a 65-year-old male that presented with classic L5 pain with some weakness. This presented somewhere else at a different institution. The SAM was okay. You can see here a sagittal and axial T2 MRI where the patient had some right-sided disc herniation, both compressed foraminal and passing nerve root. At this point, the patient got a microdiscectomy, went to work really happy without symptoms, but returned again after 2 months. Patient was again treated conservatively by this physician, and unfortunately he failed. At this point, the patient, being very active, preferred to undergo a fusion, and this is what was done at that time at this outside institution. So an L5S1 TLIF that at the time kind of looked okay. There is some end plate violation by the cage, and we can see on the last panel on the right, that's the other side. So everything kind of looks good. The patient goes back to work again. Very small, very minimal back pain, no leg pain, but then again comes back 6 months after that, and now has pain again, and now has a weakness of dorsiflexion. So at this point, the patient presents to us, and we get some scans, and this is what we find. We find a cage that completely subsided into the end plates, and there's no bone growth anywhere, if not behind the cage. So confirming our suspect of an heterotopic ossification there, and that this is compressing and dislocating L5. So this is very complicated to revise. The cage goes across midline. So the revision of a TLIF at the index level in this case prevents us from placing a cage on the other side or doing anything that it's like truly small. So we decided to come from the front and take that cage out. So we do an A-lift, we chisel that out. We go from the back, we replace the screws. We try to get in front of the thecal sac and the nerves to drill out that heterotopic ossification, but unfortunately, there's a very tenacious scar. So, we do as much of a total facetectomy as we can. The nerve appears free, and patient at this point wakes up well. Somehow, all of his pain and weakness are gone, and he does well for 18 months. At this point, he comes to my office and says, when I walk a long distance, I feel like my foot starts becoming weaker. So at this point, we do another scan, and we do also an MRI, and we see that really what's going on is that the heterotopic ossification has not changed, but there is a lot of scar in that foramen. So at this point, we're faced with a very tough choice, and some people will say do nothing. You cannot go through the scar from the back anymore. Coming from the front at this point is not possible. With L5S1, we don't really have many other options. So fortunately, about 18 months ago, in our institution, we started doing endoscopic spine surgery. And so we thought, what if we can get 2D foramen from the side? and do a foraminoplasty and remove the scar and drill out the aberrant bone, the heterotopic ossification. And so that's what we did. And as you all know, it can be tricky to get past the iliac crest at this level. Fortunately, we were able to do so and place our cannulas and working channel directly where the pathology was. And this is a postoperative CT from our drilling and opening of the foramen with drilling of the heterotopic ossification. Again, patients did really well at this point. And so this is kind of one of those cases where there are lots of things that have happened, and you don't have really many simple options. And sometimes, you know, technology, it's true that a fool with a tool is still a fool, but sometimes having a utilizing the right tool with kind of a alternate approach can really bring you to very good results, like in this case. And I think I only have a couple of minutes left, so I know the endoscopic transforaminal route has been widely discussed today, and I'm so happy to see there are so many masters around the world that are embracing this technology. Just to say a few things about the route itself. So it's very important, the targeting, as we know, targeting becomes more lateral as we go down the spine, and it becomes very tricky when we go at 5-1, and this is what I wanted to show from a paper that was published last year, where the entry point at this point and is not really a number of centimeters, but it's made by finding the iliac crest line and taking X-rays to confirm that, and coming down that direction, down the SAP. Instruments are the same. The question remains, you know, why bother with something that has a very steep learning curve? These are just a few reasons. I think there are many, many more, including the fact that the patient goes home the same day with very minimal, if any, tissue disruption. This is really where we're trying to go. So this is a sagittal MRI. We can see that the nerve sits happily in fat at the top of the foramen, and the SAP is the bottom with the place which is where we target, or let's say if we want to do trans-SAP, or more posterior, as it's been illustrated earlier, when we want to get to the disc itself. And we're able to do a foraminoplasty, increasing the space, freeing up nerves, taking pathology that also goes behind pedicle, and many other things, including fusion, from this very interesting route. And this is all I got for today. Thank you so much for having me.
Thank you, Dr. Gragnaniello. Now it's my honor to invite Dr. Nargisa and Dr. Ariba Tariq to moderate the quiz. So we are going to discuss more about this topic.